Hello, everyone, and a warm welcome to today's edition of Podcast. Today is Tuesday, 5th of July, 2022. I'm Rifat Mannan in California, and I am remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are very delighted to welcome Dr. Sanjita Ravishankar, who is an assistant professor of pathology at Case Western University School of Medicine at Cleveland. And today, she is going to give a talk on placental pathology, and the title of her talk will be Fetal Vascular Malperfusion from Theory to Practice. As always, please feel free to post your questions or comments on YouTube and Facebook chat windows, and I will pass them on to Dr. Ravi Shankar towards the end of the session. And thank you, Dr. Ravi Shankar, for joining us today. Over to you now.
Thank you. Thank you very, very much for having me, and I'm happy to be giving this talk. I hope everyone learns a lot from it, and everyone is better able to kind of take the information that we read in books and papers that we'll be talking about in the beginning. But the second half, we will be applying what we've learned from our books and papers to real cases. So I hope everyone learns a lot, and let's get started. So just a brief outline of what we're going to be talking about today. Obviously, we're going to be talking about fetal vascular malperfusion, which is one of the 4 main categories of placental pathology. And I'll show you in a minute where that kind of fits into the broader spectrum of what happens in placental pathology. We're going to go over some clinical associations, the pathophysiology, gross findings, especially in placenta. Gross findings are important in all of pathology, but particularly in placental pathology, they are really key, and you really are dependent on your grosser to find these lesions for you. And then finally, of course, microscopic findings. And then we'll, as I'd mentioned, we're going to go over some cases to try to apply what we learned in the first half to some real cases from my institution. So as I mentioned, this is kind of the broad spectrum of the different things that you can see in placental pathology. Amazingly, you can fit it all into one slide. The 4 major categories that you'll hear about are these on this side here. So you can split placental pathology broadly into vascular disorders and inflammatory disorders. Within vascular disorders, you can split it into maternal malperfusion and fetal malperfusion. Each of those can then be subsequently divided into global and segmental patterns. And then within inflammatory disorders, we have basically acute and chronic, as you might expect. In acute chorioamnionitis, you have a maternal response and a fetal response. That's a further division. And then within chronic, you have chronic velitis, or sometimes it's also called velitis of unknown etiology, and that can be split into low and high grade. So these, when you talk about the 4 main patterns or 4 main categories, this is what people are talking about. And there was a recent review paper in Modern Pathology, which kind of broke down these 4 main categories. It came from our group, and we kind of talked through and explained how we work these different things up. If you are interested, you can check it out. It was in Modern Pathology earlier this year. And then you have the kind of other category, which is fairly broad. You have villus capillary lesions, which are all the cholangiosis, craniomatous, cholangioma, lesions with a high risk of recurrence. And then finally, things that we really can't put in any particular category at all, which is just miscellaneous. And that includes things like delayed villus maturation, meconium exposure, increased nucleated red cells in the fetal circulation, the placenta accreta spectrum disorders, and placental mesenchymal dysplasia, and anything else that I forgot probably also goes into miscellaneous. So it's pretty broad, but what we're going to be talking about today is just this little piece right here. So fetal vascular malperfusion, and we'll talk about both the global and the segmental patterns. So fetal vascular malperfusion is basically a deficient perfusion of the chorionic villi due to an obstruction of fetal blood flow. This is a unified term that was introduced by the Amsterdam Consensus Conference that was published in 2016. And if you haven't seen that paper, I highly recommend taking a look at it. It has tons of pictures in it, really breaks things down. And this classification system that was formed by this consensus conference in Amsterdam is what is being used now by placental pathologists everywhere. We've all agreed to use this system of nomenclature and classification. So it's definitely a good thing to be familiar with. So prior to the Amsterdam classification, there were a lot of other terms that were being used to refer to the same concept. So some terms you might see in the older literature include things like fetal thrombotic vasculopathy or hemorrhagic endovasculitis. So these terms are no longer used, and they all fall under the header of fetal vascular malperfusion. This is just an example of a typical gross finding that we will be talking about soon that you might see in fetal vascular malperfusion. In particular, the finding in this picture is a hypercoiled umbilical cord, as you can see here. And we'll talk more about that in a second. So let's first talk about the clinical associations. So fetal vascular malperfusion, or I'm going to abbreviate it as FVM, just for to make things easier. So usually this is a disease that usually happens later in pregnancy, generally the latter half of the third trimester. So when we're getting pretty close to term. However, it can be seen earlier, including in the second trimester, or even in the early second trimester, as you can see in this really interesting case that we had here at UH in Cleveland, where you can see there was obviously an IUFD fairly early in pregnancy, and you can see how hypercoiled, again, you'll see this is a recurring theme, how hypercoiled this cord is. And then here there's also an area of stricture. So this is clearly was the cause of the IUFD. Most of the time, FVM is fairly clinically silent, and the diagnosis is usually not made until after the birth of the neonate. So, but some things that we can see when you're looking at it retrospectively, you're looking at your placentas and you're reading your clinical history, some things that you may notice that tend to happen more in cases of FVM are things like decreased fetal movement, non-reassuring fetal heart tracings, and as you can see in this case and in many other cases, there can be stillbirth. Some intrapartum associations that you may see are meconium exposure, particularly before term, as well as low APGAR scores. Finally, in postnatal associations that may occur, and this is really one of the key things that makes there be an interest in this topic, particularly among our clinical colleagues, there is an increased risk for CNS disorders, including neonatal encephalopathy, neonatal stroke, cerebral palsy, and neurodisability. And for this reason in particular, there tends to be a medical legal interest in the diagnosis of FVM as well as a possible explanation for poor neurologic outcomes later on in childhood. So this is, a fairly small part of placental pathology, as you saw in the prior slide, but it can really have quite far-reaching clinical implications for the fetus and neonate. So what happens? What does it really mean? So the kind of root of all the ills of FVM is usually in the form of some kind of umbilical cord obstruction. And we'll talk in a minute about what the different kinds of umbilical cord obstruction are and what you can see. But here's just one example, which is a true knot. But there are many other different ways that the cord can be obstructed. But the main point is that you have some kind of obstruction of the cord and the blood flow through the umbilical vein, through the cord. Remember, the umbilical vein is the one that's delivering oxygenated blood from the placenta to the fetus. Due to some kind of obstruction, you end up with stasis in the umbilical vein. which then, of course, remember varicose triad stasis leads to thrombosis. And here you can see a nice example. These are the chorionic plate blood vessels, and you can see these thrombi that have formed in these blood vessels. The vessels are dilated, and you can see the white here, which is the layering of the thrombus and the compression and blood clot in the lumen. Downstream of these large blood vessels, because you have obstruction of these vessels, the downstream vessels then, which are the villus capillaries, they then disappear. They involute and disappear, and what you end up with here are avascular villi, where the blood vessels are completely gone, or the preceding step, which is what you see on this side of the picture, which is villus stromal vascular karyorrhexis, where you can see the blood vessels are disappearing, the red blood cells are getting extravasated, and this step occurs before, eventually this step will turn into this step as they become completely hyalinized and fibrotic. So there are two patterns, as I previously mentioned, of FVM. There's the global pattern and the segmental pattern. And the names are a little tricky to get your head wrapped around, so I will try my best here to explain it. And I love using this tree analogy. I think it helps a lot of people when I explain this to them. So the global partial pattern is called that because it is a partial obstruction of fetal blood flow that affects the entire or the global vascular bed. So when you look at our tree, pretend our tree is our placenta, and here's our umbilical cord down here, which is the trunk. So if we partially cut through this trunk, but not all the way, we would globally, we would affect the entire tree, but only part of it, only partially, if that makes sense. Versus the segmental complete pattern, which is a complete obstruction of blood flow that affects one or more segments of the vascular bed. So if global partial means we cut into the trunk partially, so you're still getting blood flow through, but it's reduced, versus segmental complete is I cut a branch off completely. So then this entire branch has complete loss of blood flow, but it is only a segment of the placenta as a whole. So, but another thing to keep in mind is that the risk factors for both these patterns of FVM are the same. So as you can imagine, they can coexist. And in fact, global FVM is considered also to be a precursor of segmental FVM, because if you have something that's causing a partial obstruction, it's not hard to imagine that at some point down the line, it could cause a complete obstruction. And both can also occur in the same placenta. So distinguishing between these two in any particular placenta isn't actually horribly important because they have the same outcomes and the same risk factors. But the reason we really distinguish between these two is because the global partial pattern in particular can be difficult to recognize in a reproducible manner. And so but it does have the same consequences as the easier to recognize segmental complete pattern. And so that's why we kind of call attention to this separation to make it more clear that how to recognize this pattern in particular. So what are the gross findings we might see? So this is the concept of the umbilical cord at risk, which refers to abnormalities of the umbilical cord, which lead to obstruction. And then, as we mentioned, leads to thrombosis and or dilation of these large vessels. So you can divide into these three different categories. The first two categories are ones that we can diagnose as pathologists because we can see it in the placenta as we're examining it. So these are things like a long cord, anything above 70 centimeters we consider to be a long cord. True knots of the cord, as I mentioned, a hypercoiled cord. Anything that's over 4 to 5 coils per 10 centimeters is considered to be hypercoiled. You can have a stricture, so less than 5 millimeters in diameter. Again, these are generally talking about late preterm to term placentas, which is where this disease usually occurs. Then you can have potentially obstructing anatomic lesions, so things like abnormal insertions. You can have a marginal or velamentous or membranous insertion of the cord. You can have a furcate insertion of the cord where the Wharton's jelly ends too early and the vessels start branching before they actually insert into the disc. You can have a thin cord, which we usually consider to be less than 8 millimeters, a tethered cord to an amniotic web, usually a tight amniotic web. So this would restrict the movement of the cord. And then finally, you have this last category, which are things we can't really see grossly, but we need help from our clinical colleagues to give us the information that they observed this during the delivery. So things like a nuchal cord or a body cord prolapse during labor, or a laterally compressed cord, such as things from oligohydramnios or leiomyoma. So like we can't see these things, but our clinician colleagues can let us know if they observe these things. And of course, like everything in placental pathology, if you have more than one abnormality, the effects are more severe. And in this case, if you have more than one umbilical cord abnormality, like let's say you have a long hypercoiled cord with a true knot, now you're just increasing your risk for developing FVM. At the same time, you can have a hypercoiled cord or a long cord or a furcate cord. Any of these things can happen and you cannot develop FVM as well. So it's all just about being at risk, not necessarily that it will happen. So here I'm just going to go through a whole bunch of gross pictures just to show you some examples of these things. This is an example of a nice tethered cord. You can see here this really tight amniotic web, which is tethering the cord down to the placental surface. And so you can imagine how this cord would have a hard time moving around as freely as a normally inserted cord would. Here's a nice example of a tight true knot. And you can see the congestion of the vein on one side of the knot. Here's a nice example of a long and hypercoiled cord. And you have our scale here to see. So let's say in only 5 centimeters, we have 1, 2, 3. We already have 4 in only 5 centimeters. And remember, we were saying our cutoff is 4 or 5 coils in 10 centimeters. This is a really impressive example of monochorionic, monoamniotic twins that suffered umbilical cord entanglement. As you can see here, this is some really remarkable entanglement of the umbilical cords. And as you can see, one of the cords, this one here, which is kind of a more of a red-brown color, that is kind of the classic color discoloration you will see of an umbilical cord that you've seen in IUFD. And the other cord, as you can see, is kind of green stained, which indicates there's probably meconium involved as well. And so this is just a really nice example of umbilical cord entanglement. And here's another example of, this is one with 2 true knots, as you can see here. And in addition, you can see this green, again, green discoloration of the chorionic plate, which is fairly characteristic for meconium exposure. We usually refer to it in our gross descriptions as green stained. And then microscopically, we will see the pigment-laden macrophages, either in the membranes or in the chorionic plate or both. And as you can imagine, as I think I mentioned, meconium exposure is associated with FVM or any cause of fetal stress, and FVM is certainly one of them. And here's another really impressive example. So this is a marginally inserted cord. As you can see, it's inserted at the margin of the placenta. And it has these blood vessels, these chorionic vessels that are branching from the cord. And you can see they're huge, they're distended, and they have this yellow discoloration to them. And on cross section, what you see is that these are actually filled with occlusive thrombi that are within these chorionic plate vessels. So, and then again, there is some slight green staining that would be associated with meconium exposure. It is not only the blood vessels that you can see grossly you can see abnormalities in grossly. You can also see the avascular villi grossly if you know how to look and if the focus is large enough. So this is an example. This is in a formalin fixed placenta, which helps highlight the discoloration a little bit more. You can see it in the fresh placenta as well, but it's a little easier to see it in the formalin fixed placenta. So this brown color is the normal villus parenchyma color. Usually, blood turns kind of a brownish color after formalin fixation. And then here you can see these regional areas of white discoloration, and these corresponded to areas of avascular villi. And you can really see here how this would be an example of the segmental pattern, because it's kind of like an infarct. It's a certain territory that's been cut off from circulation, just like as if it was a infarct from the maternal circulation loss, you would again, or an infarct anywhere else, like kidney or anywhere else, you would see a wedge-shaped area. So similar idea, you have loss of vascular supply and you get a segmental loss of villus capillaries and avascular villi. So that's a nice example here of how you can actually see it grossly. So now we'll move on to the microscopic findings. So again, we're splitting this into global and segmental, keeping in mind that they often overlap. So for the global pattern, what we usually see are small foci of avascular villi or villus-stromal vascular karyorrhexis. Remember, they're both stages of the same process, so it doesn't really matter which one. And by small, what we mean is 2 to 4 villi per focus. So here's a nice example of a small focus of avascular villi. So you have one little focus over here that maybe has 4 villi involved, and then you have another tiny little focus here that has, just a few villi involved. So these can be quite subtle and difficult to find because they are so small. And I think that's a big reason why the global pattern is probably underdiagnosed a little bit, because it is difficult to see them, especially when you consider you're looking at a huge, section of placenta. It's pretty, and once I point them out to you, it's pretty easy. But if you're looking on your own, it could be a little hard to find. And that's why we'll talk about it when we go over the cases, some kind of tips and clues as to how to have an easier time finding these. The other finding that you see in global pattern FVM is intramural fibrin deposition in the large fetal vessels. And by large vessels, I mean chorionic plate or stem vessels. What these represent is an endothelial disruption due to altered blood flow, and that results in this fibrin that gets deposited in the wall of these vessels. This is different than a thrombus, which we will talk about later in the segmental pattern. Some other supportive but non-specific findings that you can see in association with global FVM include things like vascular ectasia, which is dilation of the vessel greater than 4 times its neighbor. Delayed villus maturation and patchy villus edema. The reason I kind of put these together down here is because you can see all of these things without there being FVM. And I personally would not diagnose FVM with only 1 or 2 of these lesions alone. I really need to see the evidence of the end organ or end villus damage, like the avascular villi, or I need to see the fibrin. Like, I really need to have some of these major criteria. If I just had vascular ectasia alone, I probably wouldn't mention it, because you can see these non-specific kind of findings outside of the context of FVM as well. So here's just some examples. This is a nice example of vascular ectasia. You can see how incredibly dilated this vessel is, certainly way more than 4 times its neighbor right here. This is an example of intramural fibrin deposition. You can see it's actually in the wall of the vessel, but there isn't any thrombotic material in the lumen. So this is not a thrombus, it's just intramural fibrin. For the segmental pattern, now we're talking about the actual thrombi that you can see in these large fetal vessels, so chorionic plate or stem vessels. And these thrombi can be occlusive or non-occlusive. And I usually do mention in my report, which I'm seeing, the vast majority of the thrombi you'll see in your day-to-day practice will be non-occlusive. You can also get stem or chorionic vessel obliteration, which is what we're seeing here. It's kind of like what you see in villous stromal vascular karyorrhexis. It's just happening more upstream, where you have the vessel is starting to disintegrate and disappear. You have extravasation of the red blood cells. You're losing the vessel wall. And over time, this will end up being completely obliterated and you won't be able to see the vessel at all. You can see it's surrounded by villous stromal vascular karyorrhexis in the terminal villi as well. And that is what we're referring to here. So instead of just small foci like we saw in the global pattern, when you start getting large or intermediate sized foci of these avascular villi or VSVK, now we're talking about more the segmental pattern. So large is referring to greater than 10 villi involved in a particular focus. And remember, 2 to 4 was our small, so anything in between is intermediate. Here are just some examples. So the thrombi can actually be recent or remote. When they get remote, they actually get this dystrophic calcification in them, as you can see here. And this is making contact again with the lumen of the vessel. So I would call this a remote non-occlusive thrombus involving, this looks like a stem vessel. And then here is a more advanced version of the injury that you would see in a segmental complete FVM. Here you can see where there used to be a stem vessel that's been completely obliterated. There was probably also one over here, again, completely obliterated. And all of the villi surrounding these the stem vessels, which would have been served by it as its vascular supply, are completely avascular. So this would be a very large focus of avascular villi. What is our differential? So IUFD changes, which we will spend a little bit more time on because it can be a little tricky, are definitely in the differential with FVM. Remember that the reason these downstream changes are happening is because there's cessation of blood flow through the vessels. While in an IUFD, when the fetus has died, there is no longer any blood flow. So it's kind of the same mechanism that's happening, just a different cause. So it's understandably would be difficult to distinguish, but we have some important clues that can help us, and we'll go over that shortly, as well as with our cases. Another thing that you might see is VUE, or velitis of unknown etiology, that where it can actually extend, the inflammation can extend into the stem villi and affect and obliterate the stem vessels like you're seeing here. And that, again, anytime you have obliteration of a vessel, of course, downstream you'll have the same effect where you get avascular villi. But this is not FVM. This is actually that other category of chronic velitis, or VUE. And the way we can make that distinction is that you see the associated chronic inflammation and chronic velitis associated with that focus. So you know this is not due to a primary vascular problem. This is a primary inflammatory problem. Another thing in the differential are myxoid intimal cushions. These are actually clinically insignificant. So you don't want to mix these up with intramural fibrin, which is clinically significant. It looks very similar, as you can see here, where you have this bluish discoloration and a protrusion of the intimal cushion into the vessel lumen. However, you do not see that pink fibrin in the wall. And that's what distinguishes this from the more pathologic mural fibrin deposition. And then finally, another thing to think about is sometimes you see these kind of degenerating looking villi that are surrounded by fibrin, and you might wonder if these are avascular villi. These are not avascular villi. As you can see, the stroma is more kind of bluish. It doesn't have that pink hyalinized appearance that you see in avascular villi. You have loss of the syncytial trophoblast. Usually in avascular villi, you have retention of the syncytial trophoblast because you still have preserved maternal circulation, and they're surrounded by fibrin, which you can see perivillous fibrin deposition in association with long-standing avascular villi, but usually it won't be these small foci. And usually you will still have this syncytial trophoblast, and the color of the quality of the stroma would be different. So just to kind of go into a little bit more detail about how to tell between IUFD and FVM, as I mentioned, they're both resulting in loss of fetal circulation and therefore involution of the tree. And so, of course, they'd be difficult to distinguish. The key thing to keep in mind is the temporal and spatial heterogeneity that you see in FVM versus postmortem involution. So in postmortem involution, think about it, the fetus died at a particular point in time, and that resulted in, it's like cutting off the tree trunk, right? So the entire placenta is experiencing this loss of circulation at the same time. So the involutional changes you'll see in the placenta as you're looking at your various sections will be fairly uniform across all the levels of the fetal vascular tree. So as I go from my A3 to my A4 to my A5 section, they're all going to have the same level of involution, whether that's avascular villi or villostromal vascular kererexis, the degree of stem vessel obliteration, it will all be fairly similar throughout. And we can actually use these changes to time the death to delivery interval, which is often of interest to our clinical colleagues and our patients. And that is the Guinness criteria, which are reused or have been modified since then. And you can see here in this table, the timing that we can use to determine the death to delivery interval based on the histologic changes we see. Whereas in fetal vascular malperfusion, at least some part of the loss of circulation would have occurred before the fetus died, right? And then the fetus died, and then you get the uniform loss of circulation. So you'll have some areas that are older than other areas. So if you have, let's say, villostromal vascular kererexis involving most of your placenta, but then you have a particular area which has avascular villi. Now, avascular villi means we've been around a lot longer than just villostromal vascular kererexis. We're talking about days versus hours. So that is an indication that before the fetus died, there was a loss of circulation in the fetal vasculature, and therefore it is likely to be FVM in addition to IUFD. Finally, I just want to talk about, there's a category of high-grade FVM. This is the official Amsterdam definition of it. So you have more than one focus of avascular villi or villostromal vascular kererexis, which means greater than 45 of these villi over 3 sections, or as you can do the math, an average of more than 15 villi per section. And this can be with or without a thrombus. Another way to get to high grade is having 2 or more occlusive or non-occlusive thrombi or multiple non-occlusive thrombi. And this is all kind of detailed again in the Amsterdam paper from 2016. Recurrence risk, this is something that our clinical colleagues often like to know about. Generally, luckily, FVM is usually a sporadic event and it has a fairly low recurrence risk. It's just some bad luck that umbilical cord formed that way and this obstruction happened, and it's really unlikely to happen again. The exception to this is inherited coagulopathies. So in patients with a history of maternal or neonatal thromboembolic disease, you can have a risk for recurrent FVM. A nice example of a case I had maybe about a year ago, I had a placenta with really quite terrible FVM, and the mom actually had protein S deficiency, which is autosomally dominantly inherited. So in all likelihood, that fetus also had protein S deficiency and developed quite severe FVM, actually. So in that case, that patient does have an increased risk of subsequent FVM in a subsequent pregnancy. But for the vast majority of patients, it's a sporadic event. They are, they can try again. If they had a bad outcome the first time, they are unlikely to have another bad outcome due to FVM. Plenty of things can go wrong in pregnancy other than FVM, of course, but at least FVM itself has a low recurrence risk. So before we go into the slides, I just want to kind of, since I'm going to be showing you some of our placenta reports, I just wanted to quickly go over how we here at University Hospitals in Cleveland, how we write up our placentas. I know since I kind of really wanted to take this theory and really show how we apply it to our real life cases. I know there's a lot of variability in how placentas are signed out all over America and all over the world. And I think it is the goal of the placental pathology community when they came together to create the Amsterdam Consensus was to really try to bring some uniformity to that. I really kind of wanted to share how we do things here, just as a matter of giving information. And everyone is free to take what they want and leave what they don't want, just to kind of let people know how things are done at our institution. So this is how we format our placental pathology reports. Obviously, we start with our header. And so we use the term green stain to refer to that we saw meconium staining. We don't really use the word meconium in our reports most of the time, unless it's particularly severe. But when we say green stained, our clinicians know that means we saw green, literally green staining, which often goes with meconium. I showed you a few pictures earlier of how it actually truly does look green. When we say histologically slightly immature, we mean that it is a term placenta by dates. However, histologically, it looked less than term or preterm. So slightly immature is what we mean by that. And histologically means it's only on the slides that it looked like that. By dates, it actually is truly a term placenta. This is the equivalent of delayed villus maturation. Similarly, if we had a preterm placenta that looked term, like you might see in MVM, then we would say histologically mature placenta. The weight is normal, so we just list the weight here. If the weight was abnormal, we would then have another semicolon and describing in what way the weight was abnormal, whether it was less than third or less than fifth or greater than 90th, 97th, etc. This is how we refer to seeing meconium microscopically. We say pigment-laden macrophages and membranes. This is the histologic correlate to the green staining we saw grossly. And then finally, we use this concept of the unified diagnosis with supporting gross and microscopic findings. So usually gross findings go near the beginning of our report, but when our gross finding is supportive of a unified diagnosis, we actually move it down under the unified diagnosis header. So in this case, we had findings that were suggestive of fetal vascular malperfusion, the global partial pattern. And one of those findings we saw was the thin umbilical cord. So again, less than a centimeter in diameter, actually down to 6 millimeters in diameter, so really quite thin. In addition, we saw microscopically delayed villus maturation with the nonspecific villus edema and the small foci of avascular villi and numerous of them. And then finally, we put other findings separately, so things like increased circulating fetal nucleated red blood cells. This is another common finding you'll see in association with FVM, just like the meconium, because they are both findings that are associated with fetal stress. And then if I showed this case to, in my case, Dr. Redline, then I write his name here that I showed it to him. So hopefully that makes sense, and that will give us a little context for the reports we're going to be looking at for our cases. So here we go. We'll start with our first case. Our first case is a 23-year-old. She's a G2P1. She's coming in at term. She had some sporadic prenatal care. She has some other kind of minor complications to her pregnancy. She had a vaginal delivery, and the placenta was sent to us actually for retained placenta and avulsion of the umbilical cord. The weight and the apgars of the infant seem okay. And I have a gross image here of the placenta. So kind of a funny looking one. You can see it's kind of falling apart a little bit. So there could be some issues with the completeness of the placenta. So we always mention that in our report. You can see the umbilical cord's kind of been ripped off. It's avulsed, which is the reason they sent it. And then the major finding here, as you can see, the circumvallation of the membrane insertion And you can see this yellow material associated with the membrane insertion, which is probably fibrin, but you'll look at that microscopically. And this, of course, is a finding that's associated with chronic marginal abruption. And here's our picture of the umbilical cord. You can see it's quite hypercoiled. Again, here's 5 centimeters. We have 1, 2, 3. We have 3 and 5, so we're likely to have more than 4 in 10. So now let's look at our slide. So I always start with the fetal surface when I'm looking at a placenta. So I start up here and I look at the chorionic vessels, which in this case look okay. And then as I move down towards the maternal surface, I'm looking at the fetal blood vessels. I'm looking at the villus maturity. And here we find something. This is in a stem vessel. So what you're seeing here, this is a stem vessel. Here's the vascular lumen, and here you're seeing a nice little non-occlusive thrombus sitting and protruding into the lumen. I can still get around it if I'm a blood cell, so I would call it non-occlusive. And you can see the intimal proliferation that's occurring associated with it. So here we have this, what I would call a non-occlusive thrombus in a stem vessel. Here's another one. The other one I would call recent. This one is associated with calcification, as you can see here. It's associated again with this thrombotic material that's contiguous with the lumen of the vessel. So this one would be remote, non-occlusive thrombus. And then finally, what I wanted to show you, you can kind of start noticing them even from low power. And the way I tell my residents to train themselves to find avascular villi is to start from, low power, and then you see, oh, I have trouble picking them up. So now go to high power. Okay, now I can see I have these villi that are different than the villi around them, right? They don't have any blood vessels, and the stroma is kind of pink and hyalinized looking. Okay, now I recognized it from high power, go back to lower power. Can I find them again? Okay, now go to lower power. Can I find them again? And that's how you kind of train your eye to start picking out these avascular villi, even from low power. Now that I know, okay, these are avascular villi, oh, maybe I see some more over here. Maybe one over here. Oh yeah, I was right. There they are. Finally, let's see if we can do it again. Here. There's some more avascular villi here. And this is, again, is a fairly large focus. Here's another slide from the same case. This one's really quite impressive. Here again, we have calcification in association with this fibrin material in continuity with the lumen of the vessel. So this again is a remote, non-occlusive thrombus. And again, you can start picking out the avascular villi. So this case, the way we wrote it up, so this was a relatively small, it was histologically slightly immature, and it was small, as you can see. We had findings consistent with fetal vascular malperfusion. The cord was long and hypercoiled, so we had 2 knocks against us there. There were calcified, remote, non-occlusive thrombi, as well as recent ones, and it's multifocal, and we had intermediate and small foci of avascular villi. In addition, we saw on the gross picture, there was circumvallate membrane assertion, and I did not show you, but in addition in the membrane roll, we saw chorioamniotic hemosiderosis. So those things together form the unified diagnosis of chronic marginal abruption. So in this particular report, we have 2 unified diagnoses, and we list their supportive findings underneath, both gross and microscopic. So our next case, this is a 20-year-old G1. She's almost at term, late preterm, so 36 and 3. She didn't have any prenatal care. She says she didn't realize she was pregnant until the night prior. So there were non-reassuring fetal heart rate tracings on fetal monitoring, so she went for a C-section. Weight is okay, and APGARs are also okay. On gross examination of the placenta, we saw thrombi grossly identified in the fetal vessels on the chorionic plate, as well as these pale areas that were identified that were quite extensive, involving 50% of the parenchyma. So here's the slide for that case. Again, I usually start on the fetal surface. So here's one of those chorionic vessels. And here you can see, similarly what we saw before, here's that thrombotic material in the lumen of the vessel with associated intimal reactive changes and proliferation. So that's part again of a recent non-occlusive thrombus. And then here, you can see this very large focus of avascular villi. Go on higher power. Here you can kind of get a hint. There's a little bit of karyorrhexis left. You can kind of get a hint of where the vessels used to be, but they're pretty much almost gone. Here you can see a bit of the earlier stage where you have extravasation of the red blood cells as you lose your vessels. So this is in the process of undergoing villostromal vascular karyorrhexis and avascular villi. And important to mention, as I had mentioned before, you have the intact syncytial trophoblast layer is still here surrounding the villi. And that's what makes this different than an infarct, which would be due to a maternal loss of circulation. And then you would actually also have necrosis and loss of the syncytial trophoblast as well. Because this is only a loss of fetal circulation, you're only seeing the effects in the fetal vessels, not in the maternal circulation, which is out here. Here's another slide from the same case. Here again, we're on the chorionic plate. You can see how large this thrombus is. You see the lines, the layering, the lines it's on. It's affecting this huge vessel, which is very dilated as well. This is what, when we talk about vascular obliteration, so chorionic vessel or stem vessel obliteration, this is an example. It's particularly bad in the chorionic plate, where you're seeing obliteration of the vessel. You see, similar to what we saw in the terminal villi with VSVK, where you get this extravasation of the red blood cells, you're starting to lose the integrity of the vessel, and you're getting some fibrin material here, so there may be a little bit of a thrombus associated with it as well. So that's what we're seeing here in the chorionic plate. And again, you start being able to pick them out fairly easily when they're this extensive. Here you can see the normally vascularized villi on the periphery, and then right next to it, you see this huge, large focus of avascular villi. Again, the contrast here between the normally vascularized villi and here, the more avascular villi. If we look at this stem villus right here, we can see again the obliterative changes. You can see where the vessels were, and they're starting to disappear. So how do we sign this case out? This was, again, a relatively small, in this case, it was a mature placenta. And we would call this severe fetal vascular malperfusion, the segmental type, or you could call it high grade. So there's, again, recent non-occlusive thrombus formation in the chorionic plate, villus stromal vascular kererexis of the chorionic plate and stem villus vessels, or you could also call it stem vessel obliteration, and multiple large foci of avascular villi. Our next case is a 35-year-old G2. She's again at term. We have meconium stained fluid. We have some abnormalities of the fetal heart rate and fetal heart rate tracing. This led to a stat C-section. Weight is a little bit on the large side, and APGARs were okay. So remember, this is a term placenta. And what I wanted to show you here were areas like this one. You see you have these foci where the villi are large. You have centrally placed capillaries. You have some thinning of the syncytial trophoblast layer. These are the changes that you see in delayed villus maturation. And you have this increase in the villus stroma. So here's a nice little area here. So again, you see there's so few fetal capillaries. The ones that you have are centrally placed. You have this proliferation of the villus stroma. So this is a nice example of delayed villus maturation. And the pattern in which you see it is not involving every single area. You have areas like here that look fairly okay for term, but then you see these large areas like this where it looks more delayed. And this is more typical for the pattern of delayed maturation that you see in association with FVM, as opposed to the type of delayed maturation you see in other disorders such as maternal diabetes. So I just wanted to kind of highlight that. And in addition, we have a little bit of mural fibrin deposition kind of at the surface of the vessel in a stem vessel. Because remember, I usually don't call it on the delayed maturation alone, but I do have other evidence, including this and other, again, small foci of avascular villi, which can be a little difficult to pick out. Again, here you see these areas of delayed maturation. So this is more typical of the findings you would see in the global partial pattern of FVM. So the way we would write this case up is as a, again, green stain, histologically slightly immature placenta. It has the meconium, and it has these findings that are suggestive of fetal vascular malperfusion, including the delayed villus maturation with nonspecific villus edema, the mural fibrin in the stem vessel, and some small foci of avascular villi. Okay, our next case is a 39-year-old. She's again late preterm at 36 weeks. We have some kind of bad apgars. We have a 3 at 1 minute, but then the baby recovers pretty well to 8 at 5 minutes. This is what it looked like grossly. You can see the nice hypercoiling of the cord. That's the major finding here. And when we look at the slide, again, I always start at the chorionic plate. So we're up here. So first thing we notice in this chorionic plate vessel, we have a nice focus here. See the pink in the vessel wall. So we have a nice little focus here of mural fibrin deposition. And then as we look more downstream, we have this really well-defined focus of avascular villi. And again, here you can see the contrast between the avascular villi and the normally vascularized villi that are right next to it. So kind of train your eye. You saw it at high power, train your eye to see it at lower power, and then even lower power. So this was a nice, really simple example of FVM, where I have in the same slide, I have my obstruction and my downstream effect with that gross image of a nice hypercoiled cord. This is like a nice, simple, straightforward case of FVM. So in this case, we would write it up as findings consistent with FVM, including the hypercoiled cord, the mural fibrin in the chorionic plate vessel, and the large focus of avascular villi. Okay, we have 2 more cases that I hope will be informative. So this is a 38-year-old. She's a G2. She's at 37 weeks. She's presenting for induction of labor in the setting of fetal growth restriction. And you can see all these various comorbidities that the mother had. Most interestingly for our purposes, I would point out that she was admitted to MFM 2 months prior to delivery for decreased fetal movement, and she was monitored and it was resolved at discharge. So here's our gross picture. Again, you see this nice hypercoiled cord, all twisted. Here you can see part of the placenta is missing at the basal plate. So this is again a defect, something that we would point out in our report that it's possibly incomplete. And we'd also start looking a little harder for some basal plate myometrial fibers. So when we look at our slide, again, I start on the fetal surface. First thing we find, our old friend, the mural fibrin, as you can see here, in the chorionic plate. In addition, you can see these small foci. See, there's just, 3 or 4 villi involved here. Small foci of avascular villi. And the other really interesting thing about this case if you look at some of these stem vessels, these larger vessels, there's really something odd going on with the vasculature, right? Like you have your usual, large vessels, and then you have all these capillaries that are proliferating throughout these stem villi. So you can see it here. It's kind of everywhere in the slide, this capillary proliferation. So this is actually an example of multifocal chorangiomatosis, which is interestingly associated with avascular villi. I think in one of the papers describing this entity, it was close to like 50% of cases of significant multifocal chorangiomatosis had associated avascular villi with them. So it's kind of an interesting co-finding. We're not really sure exactly why it happens. It's clearly there's some kind of abnormality with fetal blood flow that is leading to this vascular proliferation. So it kind of makes sense that you would also get things like avascular villi in association with it. So this was just a nice example of that, where you have a coexistence of FVM with multifocal chorangiomatosis. Another finding of interest, remember this placenta was incomplete. It had a piece missing. And I mentioned briefly, one of the things we look for are these basal plate myometrial fibers. So these are pieces of myometrium that came along with the placenta when it was delivered. And you can see this one is actually quite extensive. There's quite a lot of myometrial fibers here. So this is thought to be, it could be a sign of early placenta accreta, which is of course a subject of a completely different talk, but since it was a nice example, I just thought I'd like to point it out. So our report for this case, it's a disrupted, possibly incomplete placenta. We had our findings that were consistent with fetal vascular malperfusion, including the hypercoiled cord, which I showed you, the mural fibrin I showed you, and the avascular villi. We had extensive multifocal chorangiomatosis. There were some increased nucleated reds. And then finally, the basal plate with the adherent myometrial fibers. So finally, our last case, this is a 29-year-old G1 presented at 31 weeks with, unfortunately, an IUFD, which was diagnosed in the office. Her prenatal course had been unremarkable, other than she had COVID-19 with full recovery 6 months prior to her presentation. So probably a red herring in this case. This is what the placenta looked like grossly. The reason there's a chunk missing is because at our institution, they were taking samples of placentas from COVID patients for research purposes. That's why that's missing. Like we saw in that prior picture of umbilical cord entanglement, you can see how red and congested this cord is, typical of what you see in IUFDs. We also got an autopsy with this case. So this is the cord where it's attached to the fetus. And you can see here, there's an area of stricture where the cord is inserting into the umbilicus of the fetus. So that's kind of a key finding when we're looking at trying to figure out why this happened. So again, here's our chorionic plate. This is an IUFD case, so the colors are kind of gone as everything is involuting. So this goes back to what we were talking about temporal and spatial heterogeneity. And then another key thing to keep in mind is that one thing that you will not see in IUFD changes alone is things like mural fibrin or thrombi. Those do not occur as part of the normal involution after an IUFD. So if you see those things like this, again, that pink mural fibrin deposition in the wall of this chorionic plate vessel, that is your clue that this is actually FVM, not just IUFD change. And then if we go down and we look at the actual placental parenchyma, you see that the majority of it is still fairly well vascularized, right? You're starting to just get a little bit of early breakdown of the vessels. You can see here We're starting to get some early villostromal vascular karyarexis. As you can see here, again, in the stem vessels as well. But then in other areas, like you see here, they're far more along, and these are pretty, this is entirely avascular. So this is what I mean by heterogeneity, temporal heterogeneity of the involution of the fetal vessels, as well as spatial, because this area of avascular villi is large and limited to this certain area versus the rest of the placenta, which has less involutional changes. So again, it's heterogeneity, which implies that this is likely fetal malperfusion. See here, you can see the difference between the normally vascularized involuting placenta versus the lesional FVM-associated villi. So this again suggests that FVM is likely the cause of the IUFD rather than it simply being IUFD changes alone. So the way we would sign this case out is as slightly immature placenta. There's findings consistent with fetal vascular malperfusion. We had a long cord, the resimural fibrin, and the large foci of avascular villi. There was also involutional changes of IUFD along with it. So I hope this was helpful. Some main take-home points I have that I hope everyone got out of this lecture. So FVM is a recently adopted term that refers to abnormalities comprising fetal circulation. It's replacing these older terms you might see, such as fetal thrombotic vasculopathy, and it is associated with adverse fetal outcomes, including growth restriction, CNS injury, and stillbirth. It's separated into two patterns, the global partial and segmental complete, although they both can overlap and coexist, and one can progress to the other. Stasis is the key to FVM's pathophysiology. It's usually due to cord obstruction, and it is the most common underlying risk factor for both the global and segmental patterns. High-grade FVM, regardless of what pattern you're seeing, is strongly associated with CNS abnormalities. And fortunately, most cases of FVM are sporadic, and there's a quite low recurrence risk in subsequent pregnancies. So with that, I thank you all for your attention, and I'm happy to take any questions that anyone might have.
Thank you so much, Dr. Ravishankar, for this wonderful talk on placental vascular malformation. So I can see quite a few questions online from our viewers, and let me read them to you one by one.
Sure.
So the first question is, so this was very early during the talk, that are these changes a component of uteroplacental insufficiency?
So no. So uteroplacental insufficiency is another term that's used to refer to MVM, or maternal vascular malperfusion, which is a separate pathophysiologic entity than fetal vascular malperfusion. So we are talking about fetal circulation, and uteroplacental insufficiency is referring to the maternal circulation. So that we're talking about things like accelerated villus maturation, increased interstitial nodding, distal villus hypoplasia, infarcts, abruption, things like that. So it is a separate entity.
Okay, thank you, Dr. Ravishankar. So you might stop sharing your screen if you don't mind.
Sure.
All right, so the next question is, can vascular ectasia be reported in stem villi vessels or only in chorionic plate vessels?
It can be in both, yes, in both.
Okay, so then there is another, how do you differentiate between intramural fibrin deposition and non-occlusive thrombi?
So it can be definitely challenging at times, for sure, and they can occur together. Usually the way I think about it is if it's protruding into the lumen of the vessel, then I go ahead and I call it a thrombus, versus if it's only limited to the wall of the vessel, then I call it intramural fibrin. But I totally recognize that it can be ambiguous sometimes, and sometimes you kind of just need to go with your best judgment. It can definitely be difficult to tell sometimes.
So there is another question on similar vein. So how do you identify whether the thrombus is in umbilical vein or artery branch in chorionic plate vessels?
It's pretty much impossible to tell. We usually don't distinguish them in our reports. We just describe it as a chorionic plate vessel, and we don't try to guess whether it's an artery or a vein. Pathophysiologically, you would expect it to be in the vein branches, but since you can't really tell on your slide, we just kind of just don't say.
Right. So thank you. Another question that these pathological changes in the placenta, are they more frequent in association with in vitro fertilization, or is it the same with both normal or in vitro fertilization?
I am not aware of any association between FBM and IVF. The main placental pathology that you see in association with IVF is chronic velitis. And that general category of placental pathology, especially like a basal velitis or lymphoplasmacytic deciduitis, those are the things that you see in association with IVF. I'm not aware of an association with FBM.
Right, thank you. And so one of our viewers wants to know is that what is your experience regarding fetal vascular malformation, probably related to COVID-19 vaccination, or which can probably, induce coagulopathy? I'm not sure if I got the question correctly.
So I have not seen any association of placental pathology with COVID vaccination. If there was some kind of global coagulopathy in the mother, I might expect some kind of maternal malperfusion, but I would not expect to see fetal malperfusion unless the fetus had a coagulopathy, which is usually would be something inherited, like the protein S example I gave. Just to be clear, I have not seen any association of placental pathology with COVID vaccination, only with COVID infection.
Right. So this is another question. Stem vessel obliteration / fibromuscular sclerosis, is it a part of a spectrum of fetal vascular malformation?
Yes, it definitely is. So stem vessel obliteration is kind of the precursor to fibromuscular obliteration. Just it's the equivalent in the stem villi as what we would see in the terminal villi of villostromal vascular kyrexis, which evolves to avascular villi. They're the same process, just at a different level of the vascular tree, and definitely part of FVM.
Right. Thank you. So there is another question about villus edema. Do you grade villus edema?
No, there isn't a grading system I'm aware of. We just kind of describe it as patchy or global. The vast majority of the time it's patchy. The only time you would see really global villus edema would be in fetal hydrops, is the major situation in which you would see that.
Right. And so this is another one. How do you differentiate focal and diffuse delayed villus maturation and also from villus dysmaturity?
So villus dysmaturity is where you see you have kind of like delayed villus maturation. You have these large villi with increased stroma, centrally placed blood vessels, but you actually kind of have increased syncytial trophoblast proliferation and some increased knotting, as opposed to the delayed villus maturation we see in FBM, which I kind of showed you had like a more attenuated syncytial trophoblast layer. I totally agree. These things are really hard to tell apart. And it's pretty hard to describe and show actually as well. Honestly, when I first learned about it, Dr. Redline is the one who taught me about it. I had a hard time seeing it as well. And it was just kind of with experience and seeing a lot of these cases that you start to be able to pick up on the difference between this more patchy, delayed villus maturation you see in FVM cases versus the more global pattern that you see in association with diabetes, which is closer, more like the villus dysmaturity.
Right. So I think, Dr. These are the questions that I found online from our viewers on Facebook and YouTube. And I wanted to let you know that we had over 100 viewers from different countries around the world. And I could keep track of viewers who joined from Romania, Egypt, Mexico, Tanzania, Iran, Brazil, India, and the USA, among other places as well. And thanks to our viewers for your support. And if you like our lectures, don't forget to follow our Facebook page, that is Patcast, and also subscribe to our YouTube channel so that you can stay updated. And you can also visit the website, that is pathologicast.com, where you can get access to this lecture and other lectures on different subspecialties of pathology. And our next lecture is coming up. That would be on July 19th. And this would be our continuation of the series on WHO update of CNS tumors by Dr. Fausto Rodriguez from UCLA. And this talk would be on embryonal tumors. And it's again on July 19th at 12 p.m. Eastern Time. Hope to see you then. And thank you, Dr. Ravishankar, for joining us today.
Thank
And
you.
it was great having you.
Thank
Thanks
you
a lot.
very much.
Thank you.